Hello, and thank you for logging on to the Foundation for Physician Advancement podcast channel in partnership with Convey Med. FPA is a nonprofit built for and run by Marnie Reed and a group of dedicated physician educators. Our mission is to help physicians build a successful practice in today's healthcare setting through the development of your leadership skills and business acumen. I'm Marnie Reed, Executive Director, and we hope you enjoy today's discussion. This episode was recorded live at one of our Building a Successful Practice courses, so please pardon any background noise and conference references. This didactic features Dr. Michael Bolognesi leading a discussion about the current advocacy landscape and latest updates as of February 2023.
So it's the last session, so honored to be up here and speaking a little bit about value-based care and advocacy efforts, which is super important. I'm very passionate about this topic, and the folks up here with me are similarly so. So I'm just going to try to give a quick, maybe 10-minute talk and then make most of it be sort of discussion and questions, because I do think this is a, again, pertinent topic. So I think this has been touched on this morning, right, about what's around us. Certainly driving forces, a lot of those are financial in nature, and I'm going to cover, APMs, and then hopefully sort of try to hammer home to most of you that there is an opportunity in value-based care for us as a surgeon, as the specialist, okay? So that's a term I'm going to keep using, and you'll hear why. We all know this story, right? I mean, it's hard. The current market for healthcare is challenging in some states, some regions, and there's a lot of hospital closings that have occurred, and despite the fact that we're all in, good space or good occupation, there are, of course, challenges that I think were really nicely outlined in the private equity discussion earlier. Certainly, obviously, we all know this pandemic it's certainly like hurt. I'm at Duke University, and it's certainly been a challenge financially to our institution, healthcare system, however you want to think about that, and we're obviously not the only ones. This transition to outpatient care is real. It's probably the right thing to do for patients, but there also is, of course, sort of financial aspect to that, and it makes sense, certainly for the right patients, but I think we need to be people also understanding the numbers behind that. I just wanted to make sure, and some of these are Mike asked slides, but just want to make sure we also touch on the fact that there is consolidation going on, there's partnerships going on. Again, this was touched on earlier, not just from a private equity standpoint, but also from the standpoint of groups coming together. Put this in here for Cynthia, but basically it's definitely at home. It hits home. It's right here. It's in our state, and this isn't sort of the only situation like that going on. I would point out, though, and this is just one of those Becker's things, but like some of these deals go the wrong way, and they actually don't work out that well. And these are merger deals, but this is just one Becker's thing where basically there's, I guess, 5 or 6 situations that were mergers where basically the outcome was not favorable for those involved. So just think about that. I don't want to spend too much time on this, but this is real, and that's why we had a session about it in the morning. But probably more importantly, I want to make sure we all understand the space we're in right now for payment, because I think that's sort of it's a relevant topic to this meeting, and it's a relevant topic to all of you that are getting ready to go into practice, and you've heard that over and over. So I'll touch on these briefly, and again, mainly in hopes of sort of stimulating conversation and discussion for the panelists. So fee-for-service, that's where it sort of started, and that's, it still does happen. I mean, there's situations where you're paid based on the CPT code, right? So if you do hip replacement or knee replacement, you get a certain amount of, RVUs, and depending on how you're paid, that determines what the actual, money to your pocket is. And I think the challenge for that, and this is a little bit of a sore spot, is that this number has not gone up, right, historically. Everyone understand that? Like we're not it's not, it's gone down. And despite great efforts by groups like AUKUS and AOS, to try to combat that, despite the value and the efficacy of the procedure, this number has actually decreased over time and may continue to decrease. So, right, and every procedure has a CPT code, a relative value unit, and that'll come up a little bit later in the talk here. But the point is, is that's I don't know that that's what you want to bank on going forward, and that's sort of the theme of this talk. This is the traditional fee-for-service model, and of course you got, it's a patient visit. and that initiates some level of care, and you got to get the money, back obviously from the payer, whether that's Medicare or a private payer, and eventually some of that money gets back to you as the doctor. So there was this concept, and still exists this concept about a bundled payment. So you're not just paying for the procedure, right? You're paying for the procedure, the care potentially before, the care after, and maybe 30, 90, 60 days, however that bundle's determined. The initial project was what's called the ACE project, and then BPCI was sort of the middle version of that, and that was voluntary for those that were involved, and there was upside, I think, for sure for physicians. And then the mandatory portion of that was CJR, initially called CCJR, but then I guess I got in a legal dispute with another entity about what it was called. But the point is that was actually mandatory, and it's like for us, we ended up being in one of these 87 or 89 sort of geographic destinations where you had to actually, you were forced, I guess you could say, to participate in CJR bundle. So that's doing a hip or knee, right? And I'm basically getting a set payment based on your historical performance for 3 years prior to determine what you get paid for doing that level of care. And so these were the regions that were first mandated. Okay, so they're all over the country. And we ended up obviously having 2 of our 3 hospitals in one of those designated regions where we had to participate. And it's not just, again, Medicare that will do this. There are private payers that will do that, have done this, will do this, and I'll show sort of some of our experience briefly. And I think if you can perform well or outperform yourself, there's opportunity there. There always is this concern about race to the bottom, right? Because if you start cutting costs and making your total cost for the episode of care as low as possible to create upside or margin, at some point you probably can't do that any further than you already have. So if you're one of these groups or health systems or practices that were, super efficient and super low cost, these things are maybe not the best opportunity for you, but I hope to at least propose an opportunity for you at the end of this. This is just one example of our Humana, sort of agreement that we had, and I just put these up here not to show numbers necessarily, but just to sort of say we did it with multiple payers. We did one with UHC and also Blue Cross Blue Shield, and those were specific to hip and knee arthroplasty. Okay, so that's sort of what those were historically limited to for us at Duke. And the one thing I would say is that we sort of use this as an academic opportunity. And so we sort of studied these patients to look at sort of, costs, complications, certainly sort of what you do to optimize care. And you said, what's the upside of being in a bundled care program? I think you get data back from the payer, and getting that data is helpful for you from the standpoint of, if you have academic interest and certainly want to support, I guess, the decision-making about how these things go forward. And I say decision-making because I'm going to say this more than once, but like you in this room should be the people doing the decision making, right? So make sure you understand that you're the specialist. You know way better than anyone else what it takes to sort of deliver the care optimally. And so we've sort of taken it, I guess, to the next step, and that means that like we want to have the data, right, at our institution, and we want to dictate, not like CJR told us what our cost was. We want to tell the payer what the cost is. And so that's how I think you move forward. And that could be around complexity of case. That could be around sort of it's an outpatient sort of agreement, and that certainly can be around the actual patient risk, right? So what's the risk? We all study this, right? We publish about it. We know that BMI is associated with whatever, right? So just think about that. You should be the entity that is determining sort of what something should cost because you're delivering the care and you know the patient best. So I would pose to you, as we wrap this up, that procedural-based sort of approach may be actually going to the backside, and meaning that I think there's a bigger opportunity out there for a lot of us, and you could sort of say, well, it's value-based care, and I always joke, I think it's that's like a sort of fancy thing to say if you want to sound like you're cool. You say, oh yeah, value-based care, yeah. No one really understands what that is. This is actually from NEJM, and so the reality is that like control costs, deliver high value care, and also think about the payment model. Okay, and that's the one piece I don't think gets discussed enough. And so this is not really a new thing, and Duke's referenced here, but Kevin Bozick in Texas should also be recognized, as well as the payers and even CMMI. So this is an effort that started quite some time ago. That's a reality. that will be coming. So this is what they call like an episode of care around a diagnosis, something like knee arthritis, or a longitudinal bundle for conservative care as well as operative care. And the question is, I think most importantly, is like who owns and dictates that care, and it should be us, right? So that should be us. We're the specialist, we're the expert on hip and knee arthritis, and probably beyond that, not just hip and knee arthritis. And so this is be a situation where you make the diagnosis with the initial visit, and then you're paid sort of a set rate, if you will, for the entire episode of care, whether that's 12 months, 18 months, 24 months. So a completely different approach, right? It's not because you booked them for surgery. This is because you're managing their care, which we do, right? We all do that. We all take care of hip and knee arthritis or spine arthritis, or whatever it is. It should be, we should be the ones making the decisions, and obviously be the people that are driving the boat. And so at our institution, with this center called the Margolis Center, and I can't take full credit for this, but we started this from the standpoint of actually being able to do it at what we call our joint health program, and Bill Juranic, who's my partner, probably should get the most credit for this, as well as a guy named Chad Mather. And basically, this is a conservative care model. It's run by our physical therapists. We refer into the model. It's low cost, highly effective, great data about sort of outcomes of management, either prepping someone for surgery, avoiding surgery, or just managing their hip and knee arthritis. And so that is done. And so I guess you could say we sort of got prepared for what's coming down the line about doing longitudinal care bundles and diagnosis-specific bundles. And so it's an award-winning program internationally, and again, I can't take much credit for it, but I guess you could say we're ready. And maybe it's just not hip and knee arthritis, right? So it's probably beyond just hip and knee arthritis. I would propose we probably should manage everything in the orthopedic space and take that on. This is what a primary care practice does, right? So they take on lives, and I would propose to you, we got to be thinking about taking on orthopedic care for a certain number of lives, whether it's single payer, multiple payer, or even government payer. And so it is sort of a move towards capitation. There's no question about that. And some groups, I think, have already shown that you can do this. The reality is that, again, the physicians, the orthopedic surgeons are probably the people that can figure it out best to actually improve outcome, but also address costs most responsibly. So when you worry a little bit, and this is not a dig on private equity, Dana, I don't want to think about it that way, but like the opportunity here, like the opportunity private equity sees, the opportunity in this number, this amount of money, is plenty of money where you may not need to sell your practice. Sorry, I had to say. No, but it's the reality. So how does this look, right? So, somebody decides to take on the risk for the patient, right? So the orthopedic care for the patient, you agree about a certain amount of money, a certain amount of time, and then you got to manage the population in a way you do it appropriately, but also create savings. So again, not just around the procedure. This came to us from a specific payer recently, and I'll show you one slide after this. I'm about done. That gives a little bit more details. But the reality is this is for hip, knee, and shoulder. There's a target price that's 18 months, so we're beyond just hip and knee now with one payer. It's the episode's again 1 year after trigger, but 18 months total. And basically this is if you're in this bundle, you would get pulled out of any pre-existing bundles, and it's for all of our hospitals. And so this is just from a Zoom. Literally, we're on a Zoom. We're deciding what the numbers should be. We have our data on the Duke side. This payer has their data, and you make an agreement about sort of what the payment's going to be for the patients that are covered by our providers that would fall into these three diagnosis states. Again, hip, knee, and shoulder. So that it's real, right? So the point of that is that it's real. And I'll transition just into this last bit about advocacy, because the way advocacy can help us is that I was talking earlier with one of our faculty members, we probably need to think beyond our traditional payment approach, right? This is, I'm going to get a little bit out there, but like just getting paid, relative value units or going through the ruck where we really don't have a seat as hip and knee surgeons can be challenging. And we've lost on this. I was in leadership for AAOS when we did lose on this, so it's a sore subject. But I think there's still opportunity for us to sort of define how we're paid. And so, and I hate to keep saying how we're paid, but the reality is that the current process is not great, right? Again, it's determined by an entity that we really don't have full representation on, and so we don't have control over it. So I think if you were I would say, smart enough or proactive enough to try to take on the risk and take on this episode of care approach beyond a procedural approach, that's definitely something that I would think about doing. And I spent a lot of time from the advocacy standpoint on the Hill, like trying to make sure they didn't cut our hip and knee codes. And, you know, it's like a whole year of your life, you know. And then the reality is, you do all that and they cut your codes. Springer's over there like having flashbacks. But, we have to keep trying. But we probably need to be, I think, a little bit more definitive about making decisions. So we had a win, right? This is the advocacy plug, and that's why you keep doing it, even though, Brian was just there this week, and those can be frustrating at times, trips, but they're important. And the win was the optimization codes, right? So if you do these codes appropriately for someone going to the OR, you'll end up probably covering yourself back to the old, RVU value for the CPT procedures. But you got to document it and you got to do the work. But the work's being done. And CMS and CMMI, they all agreed that we were doing that work. And so that was sort of our concession that we got from the standpoint of getting these codes approved for use, again, to sort of cover our cost expenses and efforts. And so Springer, I had to throw this up here. He was just up there this week. He's fighting for us for prior authorization, which is super important, trying to make that an automated process. The bill is passed on the House side. Still needs to pass on the Senate side. I didn't put the Barrasso picture in here, Springer, but so he was in with one of our senators trying to make sure that happens. So these are real things that can happen. Imagine not having to deal with prior authorization or having to be an automated process. And that's. I think we're going to get there. I know it's a quiet time coming up for the Hill, but hopefully we'll get the Senate to do it. I would tell you guys, it takes going up there over and over and over. These are I have 8 pictures like this. Me and Springer are like stalking Senator Burr, I guess. You're probably gonna, but this is, we actually have different ties on, but I guess I have the same coat on. But no, I think the point being, is this is, it's not paid time. It's, you have to have the interest, I think, obviously to, try to make changes or help your profession. And so I would encourage anyone that has interest to at least keep me and Springer company up there in the Hill if you ever have interest going up there. So there's large groups that go. AUKUS is one group, but it's not the only one. And the main point is that, it is a very unique environment. And once you get up there, Brian was saying it really nicely earlier, like the first time you go up there, you have no clue what's going on. It's very intimidating. And then once you've been there a couple times, you can actually sort of drive the discussions that you have with it, whether it is the congressperson or the senator or it's actually their staffers. And so you learn how to, navigate that space. And then you can take a cool picture like this in front of the Capitol. But it's something I'm passionate about. And I just would say value-based care is evolving. We should be the ones, I think, that dictate how it evolves. And there's a huge opportunity. If you think just about the amount of care that is musculoskeletal and the costs associated with it, we should be the people that are running it. And there are plenty of people that are glad to step in, okay, and manage this and take on the risk and be the people that are calling the shots. But the specialists, I think, should be the ones doing it.
Thank you again for listening in. We hope you enjoyed the discussion with our FPA faculty. If you'd like to learn more about our mission or upcoming events, please visit our website at www.buildingasuccessfulpractice.org.